Discussion on interventions in the immediate newborn period. A newborn with a suspected cardiac problem is an emergency unless proved otherwise. When to suspect congenital heart disease in a newborn? Newborn with difficulty in breathing, cyanosis, feeding difficulty, undue lethargy or undue irritability, and inconsolable cry after feeding are the situations in which congenital heart disease is suspected in a newborn. Suspect anomalous origin of left coronary artery from pulmonary artery or ALCAPA if there is inconsolable cry after feeding. Physical examination is often difficult in a sick infant but should include the assessment of pulse, respiration, color, tone, activity, cry and murmurs. Occasionally, a bounding pulse with heart failure and a large heart but a near normal echocardiogram except for chamber dilatations may be due to the vein of Galen aneurysm producing an arteriovenous shunting. Many infants may be branded as cardiomyopathy if a careful examination of femoral pulse is not performed to identify coarctation of aorta. Respiratory distress with increased effort as evidenced by a tracheal tug mandates ventilation. Pallor may be noted in heart failure and cyanosis in hypoxemia. Hypotonia with severe decrease in activity suggests a severe cardiac lesion. Please note that the absence of a murmur does not rule out severe congenital heart disease. Role of X-ray chest. The X-ray chest is useful to know the state of the pulmonary blood flow, whether it is oligemic or plethoric. It is also useful for ruling out lung pathology and identifying the situs of the heart and the viscera. Oligemic lung field with a prominent main pulmonary artery segment would suggest tetralogy of Fallot with absent pulmonary valve. A large heart in a newborn should make us suspect Epstein's anomaly of the tricuspid valve or a critical pulmonary stenosis with heart failure. Agenesis of the lung, collapse of the lung, eventuation of diaphragm and diaphragmatic hernia may be seen on the chest X-ray. Hypoxia test. Oxygen may be given with a hood or mask for 1 minute, evaluating the blood before and after 100% oxygen. Saturation, PO2 and PCO2 are checked before and after the hypoxia test. The test is useful in differentiating cyanotic congenital heart disease from lung disease. Concern against a hypoxia test. There is some concern over the induction of an irreversible ductal spasm in a ductus-dependent newborn, though it is extremely uncommon. Ductal spasm can also occur even without oxygen administration. Ideally, prostaglandin E1 should be available to tackle duct spasm. Pulse oximetry in the newborn. Pulse oximetry should be done in all 4 limbs as desaturation may be there only in the lower limbs in certain situations. Obtaining a good pulse oximetry may not be easy in a sick infant. The limbs should be warm to avoid errors. The visual and auditory signals associated with pulse oximetry should be good. A good plethysmograph ensures accuracy of the technique. Role of ECG. Arrhythmias causing tachycardiomyopathy may be occasionally identified in a newborn with heart failure. Newborn hearts are extremely prone for heart failure with prolonged tachyarrhythmias. Big Q waves in lateral leads could suggest ALCAPA. Neonatal atrial flutter with 2:1 conduction and a ventricular rate above 200 per minute. Role of echocardiography. Echocardiography is the most important diagnostic tool in a newborn with suspected congenital heart disease. A systematic and segmental approach is essential to avoid missing important lesions. The coronaries should be specifically looked for. Optimum machine which is dedicated to echocardiography with a good neonatal probe is ideal. There is no need to emphasize the need for trained personnel. If a coarctation is not seen from the suprasternal or parasternal views, an epigastric view might demonstrate a coarctation of the abdominal aorta. Other lesions which can be easily missed are infradiaphragmatic TAPVC and coarctation in the presence of a PDA. Repeat echoes and second opinions are needed in difficult cases. Modified parasternal long axis view in TGA. Here we have a modified parasternal view to trace the great vessel arising from the left ventricle distally. The great vessel can be seen clearly as bifurcating into two branches. This appearance is characteristic of pulmonary artery. When aorta is imaged distally, the aortic arch with arch vessels will be seen. In this case, pulmonary artery is arising from the left ventricle, that is ventriculoarterial discordance. Aorta was seen arising from the right ventricle in another view in this cyanosed infant. There was a small patent ductus arteriosus and a small atrial septal defect. There was mitral pulmonary continuity without any conus tissue intervening. No significant subpulmonic gradient was noted. The left panel shows non-turbulent flow in the main pulmonary artery in blue color. Overall, the features were consistent with transposition of great arteries. Role of computed tomography. CT is useful in the differentiation of coarctation of aorta from aortic arch interruptions. Pulmonary venous drainage in heterotaxy may also be better seen on CT. Cardiac emergencies in the newborn. They may present with severe hypoxia, severe heart failure, or cardiovascular collapse. This could be because the anatomical lesions are critical or because of associated complications like pneumonia, gastroenteritis, or anemia. These infants are very sick and need rapid triage and management. Treatment of emergencies in infants with transcatheter techniques. Treatment of emergencies require a good teamwork of experts, good imaging, and a large inventory of hardware with preferably no constraints of cath lab time or money. The expert team is composed of intensivists, anesthetists, nurses, technicians, cardiac surgeons, and the interventional cardiologists. Newborn emergencies are very sick with associated hypoxia, acidosis, dehydration, hypoglycemia, and electrolyte imbalance. They have poor ventricular function and a low safety margin. Failed procedure in this situation would mean a higher mortality than not attempting the procedure at all. The protocol is to stabilize initially in a newborn intensive care unit and then optimally time the intervention, not too early or too late. Attention has to be made to baseline parameters, airway and ventilation, intravenous access, blood investigations, hydration, correction of anemia, acidosis, and electrolyte imbalance. Echocardiography and screening for clotting abnormalities are needed. Once the vascular access for intervention is obtained, it is almost like half the work is done. Care with contrast injection is needed to avoid cardiac and renal dysfunction in the sick neonate. Interventional procedures in newborn. Dilatation of valves, balloon aortic valvuloplasty, balloon pulmonary valvuloplasty. Perforation of valves, pulmonary valve in pulmonary atresia. Dilatation of vessels, coarctation of aorta. Maintaining ductal patency, stenting of the duct. Closure of PDA with coil or device. Balloon atrial septostomy. Embolization of accessory channels as vein of Galen aneurysm or in scimitar syndrome. Balloon atrial septostomy may even be done in the neonatal ICU in very sick infants under echo guidance. Fetal diagnosis may enable tackling of the lesion on day 1 itself. Neonatal BPV can be done with coronary guide wire and balloons. Perforation of the atretic valve in pulmonary atresia may be done with the hard end of a guide wire. The perforation is crossed with a coronary wire and serially dilated with coronary balloons. Sometimes the perforation is also stented, though it will produce significant pulmonary regurgitation. Critical aortic stenosis can also be dilated similarly. Severe coarctation can also be dilated, though it may be a palliative procedure as a bridge to surgery. Dilatation with or without stenting for an occluded Blalock toxic shunt is another transcatheter procedure. Recurrence is likely and needs a more definitive treatment. Hybrid procedures in the newborn. Hybrid procedures can be done either in the operating room or in hybrid suites. While closing a muscular VST in a sick neonate not suitable for cardiopulmonary bypass, after sternotomy, the right ventricle is punctured and a guide wire is passed across the VST. The sheath is then threaded over it, followed by device delivery. This is known as perventricular VST closure.